Good evening, everybody. Thank you, ECHO team, for bringing this together. We'll just give it maybe another couple of minutes, allowing for people to join, just a couple of minutes, and then we can start. I think we've now crossed the 50 participant mark, so I think we can start. Good evening, everybody, colleagues, juniors. Thank you, everybody, for joining. It's my pleasure to welcome the Northwest Frontier to lead us in the study of invasive fungal infections in pediatric hematology oncology. So as always, we'll start with a case presentation, followed by some laboratory perspectives this time, because that I think is really key to making the right diagnosis and moving things forward in fungal infections. And then we'll move on to management from a clinician's perspective. So first, I'd like to invite Dr. Malav Thakkar, who's a DM student at PGI Chandigarh, to please go ahead with the case presentation. Thank you. So Malav, can you share your screen, please, and start? Are you having trouble?
I'll just check with him, Dr. Vandana.
Yeah, am I audible?
These are very challenging times.
Yes, you're audible.
Yes, we can hear you.
And they will have to
My screen visible.
critical times with the various
Is my screen visible?
Yes, Malav, it's visible, but it's not in the full screen mode right now.
Okay, ma'am, now?
Yes.
Okay. Good evening, everyone. I am Dr. Malav Thakkar. I am DM Senior Resident in the Pediatric Hematology Oncology Department at PGI Chandigarh. And today I'll be discussing the clinical part, clinical case discussion part of invasive fungal infections in pediatric hematology oncology. So coming to case 1, we have 4-year-old girl child H, resident of Ludhiana, Punjab, presented with chief complaints of fever for 1 month, abdominal distension for 7 days, and petechiae for 3 days. No any other significant positive history. On general examination, child had severe pallor and ecchymosis with lymphadenopathy. Child was vitally stable and anthropometric parameters were within normal limits. Systemic examination, child had a liver palpable 6 cm below the right costal margin and spleen palpable 5 cm below the left costal margin. Other systemic examinations was unremarkable. So clinical possibility of acute leukemia was suspected and child was worked up for the same. Child had an initial TLC count of 90,000 and peripheral blood morphology was suggestive of MPO negative acute leukemia, and further workup revealed acute B lymphoblastic leukemia, and child was classified as intermediate risk as per ICICL protocol. So induction therapy was started, and after finishing first week of induction, child presented with a history of 1-day fever and left focal seizure, which was just 1 episode. Child did not have any encephalopathy. BP was just above 95th centile and other correctable causes were ruled out. So we went ahead with neuroimaging and a CECT head was done, and the CECT was suggestive of a ring enhancing lesion in the right parieto-occipital region. So this was the positive finding. So it was reported as a irregular ring enhancing lesion in the right temporoparieto-occipital cortex, likely abscess. We proceeded with a CECT chest for the patient, and we found multiple nodules in the CECT chest, multiple bilateral nodules, and there was some ground glassing which was pointing towards a fungal etiology. So it was multiple nodules in bilateral lungs and infective etiology, likely
Hello, Mala. We seem to have lost your voice. Hello. Mala, are you speaking? I can't hear you.
Am I audible, ma'am?
Yes, you are right now.
Yeah, sorry. So a galactomannan index was positive for this kid, and also beta-glucan was also positive for this kid. We proceeded with burr hole with drainage of abscess cavity, and the smear was suggestive of a septate hyphae pointing towards the aspergillus. So child was started on liposomal amphotericin B for 2 weeks, followed by injectable voriconazole for 1 week, and followed by oral voriconazole. So currently the child is on voriconazole secondary prophylaxis with voriconazole levels being monitored, and a repeat MRI was also suggestive of a radiological resolution of lesion. So plan is to give voriconazole secondary prophylaxis till the end of TI2. Coming to case 2, we have an 8-year-old male child who is a known case of standardized BLL post DI1 and presented with complaints of headache for 5 days, drooping of right eyelid for 1 day, and decreased vision of right eye for 1 day. However, there was no fever. On examination, child had right, second, third, fourth, and sixth cranial nerve palsies and did not have any proptosis. So a CCT chest and PNS was done, which was suggestive of pansinusitis. Surgical debridement was done, which was suggestive of a aseptate hyphae and was consistent with mucormycosis. Child received liposomal amphotericin B for 8 weeks. But despite this, child had persistence of symptoms in the form of persistent headache, right ptosis, and blurring of vision. A CT angio revealed a thrombosis of the internal carotid artery and also an infarct in the right basal ganglia. A repeat debridement surgery was done, and again the histopathology was consistent with mucormycosis, following which the child received liposomal amphotericin B for 1 more month, after which there was resolution of symptoms, child was symptomatically better, and then was shifted to alternate day liposomal amphotericin B for 6 months. Coming to the third case, we have a 6-year-old male child resident of Jammu presented with complaints of fever, bone pains, and progressive pallor for 1 month. On examination, had pallor, cervical lymphadenopathy, and a hepatomegaly with a spleen tip palpable. So on further workup, child was diagnosed as risk.
We can't hear you again, Mala.
And his slides are not moving. Maybe there's something wrong with his internet.
Shall I project the slides, Dr. Richa? Maybe you can.
Right. I'll just see if he can join back in a second.
Yeah, sure.
Otherwise, maybe we can, because he's presented 2 cases, maybe we can go with the next presentation.
Yes.
I'll just confirm in a second.
Yeah.
He'll try to join from the phone, Dr. Vandana. If you can project the slides, please.
Okay.
Sorry for the interruption. So child had reached the consolidation phase on R3, and during consolidation, child presented with fever and cough for 5 days. However, initially, child was started on first-line antibiotics, followed by persistence of fever and neutropenia. Child was shifted to meropenem. However, as neutropenia resolved, child started having skin nodules and also had hepatosplenomegaly. So hepatosplenic candidiasis was suspected as the neutropenia was resolving and child continued to have fever. So a USG abdomen was done, which was suggestive of multiple hypoechoic splenic lesions and a disseminated candidiasis, and a hepatosplenic candidiasis was suspected. Initially, child was started on liposomal amphotericin B and fluconazole. However, there was no defervescence of fever and prednisolone was added for 1 week, post which there was defervescence of fever. So further workup, so child had serology positive in like beta D glucan was positive, and radiologically the MRI was done, which was suggestive of multiple hypointense lesions in liver, splenic parenchyma, and bilateral kidneys. So as mentioned earlier, child received liposomal amphotericin B and fluconazole and prednisolone in view of non-effervescence of fever. Further workup.
We seem to have lost Malav again.
Yes, I think so. Perhaps we can move on to the next presentation.
I suppose so.
Once this screen share disappears.
Right.
It's our pleasure to welcome Dr. Gaurav, Associate Professor in Microbiology at Tata Memorial Hospital, Mumbai, to our online training program. Welcome, Dr. Gaurav, and we look forward to hearing your thoughts on laboratory diagnosis.
Thank you, ma'am. Can you see my presentation now?
Not yet. We can hear you quite well.
Yeah, is it visible now?
Yes, we can see your screen.
Yeah, thank you. Thank you for giving me this opportunity, and I'll be talking about diagnosis of invasive fungal infections from a clinical perspective. As we all know, when you talk about invasive fungal infection, probably the most contributing factor is Candida, which contributes almost 70%. Second most is Cryptococcus, and then Aspergillus.
Sorry to interrupt,
Yeah,
Dr. Gaurav. I think we're only able to see a different screen that you're sharing with us. I think perhaps you're not sharing your slides screen.
Okay. Is it now visible now?
Yes, yes, yes.
Yeah, thank you. So when I talk about invasive aspergillosis, probably Canada contributes to 70% of the cases, followed by Cryptococcus and then Aspergillus. When it comes to mortality, it is Aspergillus, which almost contributes to almost 40 to 90% of the cases. We have even endemic cases. They are usually dimorphic fungi. As of now, today, 2 more organisms have been officially added to the list of AMR threat by CDC, mainly Candida auris and Aspergillus fumigatus. Yeah, probably this is the age-old slide which we have seen in case of hematopoietic stem cell transplants. Candida is generally seen as early onset infections, and later on Aspergillus, Fusarium or Mucor might take it. I'm going to talk basically on 4 topics. One first will be microscopy, second will be cultures, then antigen antibody reactions, and then molecular methods. When you look at microscopy, it helps us to see stain smears or smears from clinical specimens. Now, this could be simple stains where we see H&E, probably this is a slide of an aspergillus, or in gram stain, which we can look out generally for yeast cells. But sometimes these fungal elements can be misinterpreted as artifacts. When we use a bronchoscopy material or a tissue biopsy, we generally restrain to special stains, which could be passed to look out for fungal hyphae. And now the calcium staining, the fluorescent staining has taken over from KOH. So these generally, you can see the fungal hyphal elements against a dark background. So screening becomes very easy. We could also use an Indian preparation where you can see the capsule, which is unstained, and the yeast cells with budding in case of Cryptococcus. And in case of PCP, we could see on a Gomery's methylamine silver staining, which helps us to visualize things much better. So the whole idea of doing a microscopy is it just gives you a valuable diagnostic clue on what could be the nature of the positive organism. Example, in mucor, we could see ribbon-shaped non-septate hyphae, or in case of aspergillus, we could see septate regular hyphae, or if it's few hyphomycosis, we could see melanization. But then in order to come to a presumptive diagnosis, which requires a lot of experience and a reliable identification of fungus solely on the basis of morphological criteria or histopathology staining, might be difficult. That is where culture techniques come into picture. If you are doing cultures from sterile body fluids or biopsy material, the results are quite reliable. But when you take specimens from a non-sterile site, the results could be little differential because there could be an element of contamination. Generally, even in Candida, from blood, the positivity rate is less than 50%. And in conventional blood cultures, the isolation rate of yeast is more than that of molds. For this reason, we generally recommend to send a paired sample, 2 samples, one from peripheral vein, other from the central lines. This increases the chances of isolating a fungus. There are some studies wherein they have shown that a dedicated fungal bottle, maybe all of you must have heard, called Bactec mycosis F, might increase the isolation rate of Candida. Especially Candida glabrata might be isolated more from anaerobic bottles. When we found that the benefit in fungal recovery was almost negligible in these cases. In fact, it added more to the cost to the patient. So if Candida glabrata is probably your target pathogen, then probably you could use anaerobic culture bottle. But in general, we do not recommend the use of dedicated fungal bottles, especially for increasing the isolation of Candida. Candida is generally a normal flora of the upper respiratory tract, the upper GI, and the lower GI. So if isolated from any of sputum or bronchial or the bowel sample, generally considered as contamination or colonization, unless and until there is a candidemia or a lung biopsy which shows the presence of Candida. Similarly, if Candida is isolated from urine, we generally prefer to ask for a repeat sample. And on the second sample, if the same organism is isolated, we consider that to be pathogenic. Unless and until we have a severe neutropenic patient who does not have a urinary catheter, and there are clinical indications that he or she might be suffering from UTI, then presence of Candida in such cases is considered significant. The time to positivity in cultures is generally prolonged when the patient is already on antifungal agents. That's why, and another thing we generally recommend is after we have diagnosed the case of candidemia, the blood culture should be repeated 2 to 3 times after initiation of your antifungal therapy. An ophthalmoscopy should be done, and UAG ultrasound to rule out abdominal focus, and echo to see if there is hematogenous seeding of Candida in other cells. In case of suspicion of Cryptococcus, we generally check both CSF and serum. Blood culture should be done, and you could do a special staining like India on the CSF to get an early provisional diagnosis what could be the pathogen. Generally, we incubate cultures at 2 differential temperatures, 37 and less than 30 degrees. If molds are isolated from at lower than 30 degrees, then generally considered as contaminants. A culture report is probably followed with an antifungal susceptibility report. It is a mandate. Usually, we do not have any specific reference MIC values. That is why the interpretive criteria is generally not mentioned in many of the reports. If you have a Candida or glabrata, you should definitely check for resistance to azoles and echinocandins. If you have Aspergillus fumigatus or fusarium, then should be definitely checked for resistance to azoles. Now, we could also determine presence of resistance mutation as FKS12 probably indicates resistance to echinocandins in Candida, and detection of CYP518 detects resistance to azoles in Aspergillus. Remember one thing, some of the strains of Aspergillus fumigatus, which might be negative for CYP51A mutation, might show azole resistance on phenotypic test. Although conventional cultures remain the cornerstone of diagnosing fungal infections, they are to be heavily relied upon the expertise of person who's performing it. Also, they have a lower sensitivity, a higher turnaround time, almost 1 week for Candida and almost 4 weeks for molds. It also depends on how good the specimen is. And for good specimen, the procedure are mostly invasive. That is why we sometimes, many times we are resorting to antigen antibody reaction. The advantage is we don't require an invasive sample. It can act both as a diagnostic, as a prognostic marker, and serologic tests tend to be positive in cases where culture tests are negative or where we are not able to identify the fungus. So we have an antigen test for Histoplasma capsulatum. Generally, a urinary antigen test is done. For Cryptococcus neoformans and species, including Cryptococcus gatti, we have another immunochromatographic test. Generally, the sensitivity is around more than 85% and specificity is more than 95%. We generally do the CSF and serum in parallel. Nowadays, the POCT tests are available. The only thing you should be taking care of, these tests generally contain capsular antigens against all 4 serotypes against both Cryptococcus neoformans and the Gatti complex. Antibodies is something controversial. We have seen that antibodies against Aspergillus are very rarely detected in immunocompromised patients. Therefore, their role in determining an invasive pulmonary aspergillosis is doubtful. Similarly, anti-Candida antibodies have poor sensitivities. That's why their role in immunocompromised patients is less reliable. Galactomannan antigen in serum or bile is probably most commonly performed. The Galactomannan ELISA assay from Petila is probably the only approved kit. It has a very high sensitivity of almost 80 to 100%, specificity of 90 to 100%. The negative predictive value is pretty high, more than 90%. And only thing is, it is not specific for Aspergillus fumigatus. It can be released by other species of Aspergillus, as well as Fusarium and Histoplasma capsulatum. The clinical cutoff that usually is kept as 0.5 for serum and 0.5 to 1 in bronchial level sample. The moment you increase the cutoff above 1 to 1.5, the specificity and the negative predictive value increases, but the sensitivity decreases. If you decrease the cutoff below 0.5, your sensitivity increases at the cost of specificity and negative predictive value. Generally, galactomannan levels are can be detected prior to clinical suspicion of infection. Therefore, they can be also used for monitoring of therapeutic disease. We can have false positive reactions in patients who are already on beta-lactam antibiotics like Piptaz, or patients who are having multiple myeloma or receiving nutritional supplements. We could have false negative results also if patient is on long chronic antifungal therapy. If there is a decision to be made between serum galactomannan levels and bronchial lavage, then the bronchial lavage galactomannan levels are more indicative of invasive fungal infection as compared to the serum levels. Nowadays, lateral flow assays are also available, but we have few data available to determine its diagnostic value. The question is, how often should we be doing galactomannan levels? So if you're using it as a diagnostic marker, then you can repeat the sample another time. If you're using a screening marker in high-risk patients, then you should be doing it twice weekly. The predictive value of galactomannan increases when it is generally combined with PCR or BDG levels. Now, coming to BD-glucan, generally secreted by Candida, Aspergillus, Fusarium, Acremonium, PCP, and endemic mycosis. Generally not secreted by the yeast phase of blastomyces, mucor, and generally low or absent level when we have cryptococcal infection. Similarly, false positive results can be seen in receiving patient receiving infusion fluids, nutritional supplements, and other materials which contain beta-glucans. The sensitivity, as since it's a pan-fungal marker, the sensitivity varies from 55 to 100%. Specificity is around 80 to 90%. Has a reasonable predictive, positive predictive value of 70 to 80%, and negative predictive value ranges from 70 to 100%. Now, Fungitel is the only kit which is approved as of now. It can detect you can find BDG levels in disseminated histoplasmosis, but poor levels are seen in blastomyces. In labs generally which have low output levels, they could use a fungistat, which is a simple single patient option, and it's an adaptation of the original Fungitel kit, which has comparable positive predictive value and negative predictive value. Coming to molecular platforms, probably PCR is the one. Initially, we used to have pan-fungal PCRs, which is to target the ITS1 region. But now there are specific fungal PCRs available, which could selectively look at Aspergillus, other species, along with their resistance markers. Only thing is, usually PCR generally tend to have a high negative predictive value. That means if it is negative, you can then less likely the patient will probably have a fungal infection. So commonly ones, now we have shifted from PCRs to multiplex PCR. Now, multiplex PCR, the advantage is you could look at multiple targets. Commonest example most of us be using is BioFire, where they have two panels which detect fungus. One is the meningitis panel, which picks up Cryptococcus, and the BCID or the sepsis panel, which looks at 5 important Candida species. Now they added Candida auris and Cryptococcus also to it. There could be other platforms available in the market like Septifast, which picks up almost 21 different fungal pathogens, including bacteria, and they have shown advantage in hematological patients who are receiving chemotherapy. The ePlex is another system which around 16 species of fungus, in addition to bacterial pathogen as well as resistance markers. T2 Candida system is something which I like to stress about. Like BioFire, if you send your blood culture needs to flash positive, and then you do a smear. Once you see an organism, and then only you generally you put in the request or run it on the BioFire system. But in T2 Candida, you don't have to do that. You just have to take 2 to 4 ml of whole blood. The turnaround time is less than 5 hours. The best is the limit of detection is almost 1 to 3 colony forming units per ml, as compared to other conventional PCRs where the limit of detection is generally more than 100. The sensitivity in T2 Candida is almost 91%, and the specificity is near 100 with a negative predictive value of near 100 again. So it picks up 5 most common Candida species like albicans, tropicalis, parapsilosis, cruza, and glabrata. And now they have added the escape group of organisms, E. coli, staph, Kleb, Acinetto, and Pseudomonas. So that makes it more convenient. We have newer and upcoming techniques. Probably this requires a lot of study and we don't have adequate data to say how useful they could be. Namely, they are DNA metabarcoding, there is NGS, there are electrochemical biosensors, there are microfluidic based detections, and CD154 positive T cells. So which are specific for fungus. So all these systems generally use AI. So basically the core of all the systems is artificial intelligence. Now, question is, could we use a single marker? No, you have to use a combination of markers. Studies have shown that when you combine galactomannan with beta-glucan, we get more clinically meaningful results. Or you can combine galactomannan with PCR, shows to have high sensitivity to detect invasive aspergillosis. So current recommendations is generally combination of a non-culturable test with PCR. So generally we go with galactomannan with PCR. We could add BDG to it to increase its sensitivity. Various studies have shown that even the invasive aspergillus-free survival period is higher when you use combination of galactomannan with PCR as compared to galactomannan alone. This helps us to detect the pathogen earlier, initiate treatment early, saves really cost from 33% to 17%, longer duration of stay in the hospital, and better survival. We had done a small study, a 6-month study in our institute from Jan to July. This was basically in bronchial larva samples, almost 600 samples were there, which showed positivity for molds of only 17%. In these 103 samples, galactomannan was positive in 62% of the cases. 36 of these patients showed prior history of tuberculosis, and 11% of these cases had history of COVID-19. We tried to see what was the radiological picture comparison. Almost 75% of these cases showed a positive radiological picture. And if you could see the isolates, again, most common is Aspergillus, amongst which Niger was the most common, followed by Penicillium species. Then we have Paecilomyces fonseca. Pitomium and Geotrichum are generally contaminants, and 1 or 2 isolates of Scidoperium, Fusarium, and Acrimonium. Another 1-year analysis we did of Candida species isolated from blood, Candidemia. Our most common species in our institute is probably Candida tropicalis, followed by Parapsilosis, albicans. And in year 2022, we isolated only 5 cases of auris. Now, this pattern might vary from institute to institute, but just to stress, non-albicans Candida has taken over Candida albicans as the most common Candida species, probably isolated from cases of Candidemia. Thank you. Probably that is what I have to say.
Dr. Gaurav, for that wonderful overview and telling us about the various diagnostic methods available to us for fungal infections, for making a diagnosis of fungal infections. I request you to remain in the meeting, please, so that we can take questions at the end from our delegates in the meeting. Now I welcome Dr. Richa Jain, who really needs no introduction to this audience, but Associate Professor at PGI Chandigarh. Welcome, Dr. Richa. We look forward to hearing your perspective on prophylaxis and management. We can't hear you.
Right. Am I audible now?
Yes.
And is my screen visible, full slides?
Yes, full screen visible.
Great. So thank you very much, Dr. Vandana, and thank you to the ECHO platform. So my talk will be focused on prophylaxis and management in pediatric oncology patients. So my question to the people attending this talk is, which patients out of these that I have listed do you think need antifungal prophylaxis? I'll just switch on my pointer here. So, right. So all children with ALL in induction and consolidation, yes or no? All children with AML, yes or no? All solid tumor patients undergoing ASCT, neuroblastoma, brain tumors, etc. Relapsed leukemias, and allo-HSCT patients. So to answer this question, the basic answer of this question is all patients whom we consider to be at a high risk for invasive fungal disease, they merit prophylaxis. So this would be primary prophylaxis, where the patients are treatment naive, fungus, they have not had a previous fungal infection, and we are giving the prophylaxis to prevent development of fungal infection. And whereas patients who have had a prior invasive fungal disease, who are going to receive further chemotherapy, T-cell depleting therapy, ATG, stuff like that, and we are anticipating prolonged neutropenia or immunosuppression, they would merit secondary prophylaxis to prevent development of invasive fungal disease yet again. So these are the patients who need primary prophylaxis and secondary prophylaxis. So in this list, who are the patients whom we call high risk for invasive fungal disease? Practically all AML patients are at high risk for invasive fungal disease because they have prolonged periods of neutropenia and immunosuppression. Specific phases of ALL treatment lead to prolonged neutropenia, typically BFM consolidation and at times augmented BFM consolidation for intermediate and high risk leukemia are high risk patients. Children with relapsed leukemia, whether AML or ALL, who are on the second treatment, they are all severely immunocompromised and they are high risk. Patients undergoing allogenic transplant before they have engrafted, or if they have developed graft versus host disease, they are at high risk. Children who are receiving high dose corticosteroids, which is for prolonged period like more than 10 to 15 days, are at high risk. However, though this constitutes most of the children with ALL induction, we don't see still we don't see a very high degree of infection in all ALL inductions. So it's an institute to institute policy whether they should be considered high risk for invasive fungal disease or not. And mostly patients with various primary immunodeficiencies and acquired immunodeficiencies would be considered as high risk. So who is not a high risk? Most of the children with standard risk ALL on induction who are not getting any anthracycline, despite getting steroids, are not at a very high risk for invasive fungal infection. Standard risk consolidation is definitely not at a high risk of invasive fungal infection. And autologous stem cell transplant is absolutely not at a high risk of fungal infection because these children graft very rapidly and they have no risk of developing GVHD. And almost all solid tumor chemotherapy, they are not at high risk of invasive fungal infection, except for very few relapse protocol, which are very intensive. So why is primary prophylaxis important? Because as you just heard from the previous two talks, mortality with fungal infections is quite high. In children with ALL, this is world over data. So though the incidence has been noted to be around 1%, it has a disproportionate mortality of about 20%. Whereas in AML, the incidence is higher, 12 to 20%. So definitely primary prophylaxis is important. And this incidence has come down to single digits, 3 to 5% in most of the places with routine antifungal prophylaxis. And disproportionately, fungal infections lead to 60% of infection-related deaths. Similar data in allogenic transplant patients with 12 to 16% incidence and more than 60% case fatality. So, like I said, primary prophylaxis is given in patients who have not yet had any invasive fungal infection, and we are anticipating a lot of chemotherapy and immunosuppression. Institutional practices vary, and every institution has their own high risk definition and their drugs of choice. However, ALL in specific phases of therapy, patients with AML, all AMLs, all relapsed leukemias, and allogenic stem cell transplant patients are all considered for primary antifungal prophylaxis. The drugs, while a lot of articles and a lot of guidelines mention fluconazole still as being the drug of choice, it definitely has the caveat that it will not cover any of the molds, whether it be aspergillus or mucor. So the alternate that can be considered is voriconazole. And at PGI, in certain patients, we do give voriconazole for AML patients and ALL patients getting BFM consolidation. We end up giving voriconazole in very specific time points. another alternative which is practiced in certain places is low dose or alternate day amphotericin B in very high risk patients. Secondary prophylaxis is given to patients who have had a prior history of fungal infection, which has subsequently resolved. And we are anticipating subsequent periods of immunosuppression and prolonged neutropenia. The choice of drug here depends upon what was the kind of prior invasive fungal disease and what is the clinical status of the patient. So coming to when we suspect invasive fungal disease. So basically, this is something that everybody who is doing hematology oncology would know, that all febrile neutropenic patients who have persistence of fever beyond 3 to 5 days, despite appropriate broad spectrum antibiotic cover, in whom we are getting cultures negative, who do not have any obvious viral infection and assays are negative. So these are the patients in whom we suspect invasive fungal disease, and at times we start empirical antifungal therapy. As it was mentioned in the previous talk by Dr. Gaurav, internationally, Candida is considered to be the most common fungus, followed by Aspergillus and Mucor. However, the data, while not so very robust from India, indicates that Aspergillus may be more common fungus for us. And at our center, definitely it has been more common. And this is published also. So this is a slightly older article, 5-6-year-old, when we noted our experience with invasive fungal disease and acute leukemia over 8 years. We saw that the prevalence was around 7% in all leukemias, ALLs and AMLs, of which proven fungal infection was 69%, probable was 16%, and possible was 15%, with lungs very frequently involved and Aspergillus being the most common fungal infection. Deaths occurred in 44% of the patients, and Aspergillus accounted for majority of the deaths, with Candida also having, children with Candida also unfortunately had significant percentage of them died. And underlying AML predicted higher mortality. So when should a child undergoing chemotherapy be initiated on treatment for invasive fungal disease? Definitely, if we have presence of proven fungal infection, which is either a histopathological, microbiological, or a culture diagnosis, we need to start antifungal therapy. And this, however, proving a fungal infection takes quite a bit of effort and time. And at times the children we are treating do not have this kind of time. So most of the times we end up starting antifungal therapy when only for probable or possible fungal infection, which is if persistence of fever is there beyond 4 to 5 days or other clinical features and radiology are suggesting invasive fungal disease. So this will be empirical antifungal therapy most of the times rather than definitive. So what are the features which predispose a person to fungal infection? Some are the host features, which we have already talked about to some extent: neutropenia, allogenic transplant, prolonged and high dose of steroids, other immunosuppressive therapy, or congenital immunodeficiency. Clinical features like nodular lesions on the skin, air crescent sign on the chest, either an X-ray or a CT or an MRI, presence of a cavity in the chest X-ray, nodules in the chest, in the CT are all features, radiology and clinical features, which suggest a fungal infection. And microbiological features are culture or a direct microscopy or cytology, and serological assays, which we have talked about, galactomannan and beta-D-glucan. So proven is presence of histopathological diagnosis, probable is host criteria should be met. So we have an immunocompromised child who has some clinical features as well as possibly a serological feature or BAL, which is showing Aspergillus or something like that. So this will be probable invasive fungal infection. Possible fungal infection is considered when host and clinical criteria are met, however, microbiological criteria are not met. So majority of the children fall in probable and possible invasive infections, whereas few only have proven fungal infections. So what is the portal of entry of these fungus in our body? Candida is a common pathogen, common cell in our gut. And typically it enters when the gut mucosa is breached, our defenses are breached, as well as mold, especially mucor, translocates from the gut. Skin inoculation occurs in Aspergillus and mucor. Catheter-related bloodstream infection is noted more commonly with Candida than with Aspergillus or mucor. rhinosinusoidal and pulmonary infections are caused by Aspergillus and mucor typically. So coming to invasive candidiasis, what are the clinical features? So prolonged fever, obviously, skin nodules are at times seen. We might see organomegaly like hepatomegaly and splenomegaly with high-grade fever. And if we do radiology like ultrasound or a CT, we might come up with nodules or abscesses in liver, spleen, or kidneys. This is hepatosplenic candidiasis. At times, we send a blood culture anticipating bacterial infection, but the lab calls us back to say that we are growing yeast, and we are doing further analysis to tell you what exactly is this yeast. So we might see a blood culture positivity in a febrile neutropenic child, and catheter or PIC culture positivity might be present. CNS infections, abscesses might be present, eye infections may be present. Practically, Candida can go to any organ and cause abscesses in these organs. So this is an example of, you can see skin lesions here, multiple skin nodules. This was caused by, in a child with ALL who had developed disseminated candidiasis. So a biopsy of these lesions was sent to histopathology as well as microbiology, and that confirmed our diagnosis of Candida here. So what are the investigations to be done when we are suspecting candidal infection? So a blood culture, which Gaurav mentioned, skin biopsy should be done if nodules are present. And I hope I am audible and visible. Dr. Vanna, can you please confirm?
Yes, you are. Thank you.
Okay, thanks. So if we are growing Candida from anywhere, then it is important to do a fundal examination, because very characteristic fundal lesions may be obvious and which are diagnostic in themselves. Serological assays, specifically beta-D-glucan, can be done to help us in our diagnosis, but it is not really very confirmatory, which I'll talk about in a little bit more. And once we have identified that we are growing yeast or Candida from any of the sites, then species identification becomes very important, because there are certain species which are inherently resistant to azoles, glabrata, auris, and cruzi. If we are growing glabrata, which we do occasionally see, an auris, cruzi I've never seen before, and I think even in the TMH data, they didn't show any cruzi, but all these three are inherently resistant to azoles and would require liposomal ampho or an other alternative agent in case we are growing any of these. So a drug sensitivity testing, if available, is great. However, again, this is time consuming. And if we have a case of hepatosplenic candidiasis, then at times we do need to monitor serum ferritins, because they may have some degree of associated hemophagocytic lymphohistiocytosis. What is the treatment of these children who develop invasive candidiasis? So the drug of choice is echinocandin. Capsofungin is the drug that we typically give. It's parenteral invariably. It does not have an oral formulation. And the duration which is recommended is 2 weeks after clearance from bloodstream infection. And multiple blood cultures are required if we have once grown Candida from the blood culture. If there is organ invasion, liver abscess, kidney abscess, splenic abscess, any other muscular abscess, brain infection, then definitely there will be a longer duration required. At least 6 to 12 weeks would be required till there is clearance of all those abscesses. The dose of capso is 70 mg per meter square initially, followed by 50 mg per meter square once a day. An alternative agent which is very effective as well is liposomal amphotericin B, and this is the preferred agent along with voriconazole in patients who have either a CNS or an ocular Candida infection. In ocular infection, intravitreal injections can also be administered for azoles. The other important part of treatment is that we need to reduce immunosuppression. If we have a bad invasive candidal infection, then we really need to stop chemotherapy on the patient, preferably stop the steroids. If it is a child with acute leukemia, stop chemotherapy, stop the steroids, and give the child time to recover his immunity, because that is going to really help with fighting the candidal infection. If the child has a CVC which is infected, then it should preferably be removed. Unless we absolutely cannot do without it, it should be removed ideally. And if there are disseminated infections, then I just said that requires a longer course of treatment than just blood candidemia. Hepatosplenic candidiasis is a specific type of infection, which typically happens when the children have neutrophil recovery. Children with acute leukemia, we see it most frequently in children with ALL who have at their neutrophil recovery. They develop very high grade, very alarming fevers and develop small livers and spleens after a couple of days. And once we do radiology, initial radiology is ultrasound, we see some salts, granulomas or small abscesses, and which can be confirmed on CT or MRI. MRI is considered to be the most sensitive means for diagnosing this. Treatment for the confirmation here would ideally be by FNA or a biopsy. However, in a characteristic situation and with a positive serology, at times empirical, it can just be considered to be hepatosplenic. Sorry, am I audible? Is there a problem?
Yes, yes,
Okay.
you're audible.
Okay.
Request everyone else to please mute. Thank you.
Right, thank you. So, while the treatment is ideally with the kinocannins or amphotericin B, and it should be given till symptom and radiological resolution happens, which may take quite a few weeks. At times, fluconazole practically may suffice in children who are at low risk, especially if we are using it as a step-down therapy after giving intravenous amphotericin for about a week or so. And for this, despite giving appropriate therapy, we often see that these children do not have fever effervescence, and these children typically require some low dose of steroid to have effervescence. So prednisolone 1 to 2 mg, typically 1 mg is enough for most of these patients, is required for a period of 3 to 7 days. And subsequently, there is a very rapid effervescence of fever in these patients. And if there is not, then we need to assess for associated hemophagocytic lymphohistiocytosis, which may occasionally be present in these patients. And in which case, while we do not give full-blown treatment for HLH, we do need to give higher degree of steroids and maybe IVIG at times. So coming to the next infection, the molds, which are clinically most important molds, are Aspergillus and Mucor for us. So 95% of all fungal infections in pediatric oncology are caused by Candida, Aspergillus, and Mucor. Very rarely we see other fungal infections like Fusarium or Cryptococcus or Histoplasma. So what is the clinical presentation of these molds? Typically, it is with a persistence of fever and neutropenia and development of pneumonia, rhinosinusitis, at times brain abscess, like was the case in the initial cases which were presented by Dr. Malav. The brain abscesses may be single or multiple. However, they typically have surrounding significant edema. There is no very easy way to differentiate on radiology whether it's a bacterial brain abscess or a fungal brain abscess. Skin infections may be present in the form of nodules, which may at times be hemorrhagic, which may just be slightly tender and maybe only felt if we are doing the palpation very meticulously. In the gut, we can see neutropenic enterocolitis or an intra-abdominal mass at times. This is typically caused more frequently by Mucor than by Aspergillus in the gut. So when we have a child with prolonged fever, neutropenia, who is not improving, what are the clinical pointers towards fungal infection? So there are very few clinical pointers. So one is the obvious one, persistence of fever despite adequate, appropriate broad spectrum antibiotic coverage. If we are seeing a child who has developed proptosis, please think fungal infection. Like a child with ALL, febrile neutropenia walks in with a proptosis, think of rhinosinusoidal and going inside the brain fungus. Presence of rhinosinusoidal discharge, especially if it is bloody or blackish, then again we should think of invasive fungal infection of the rhinosinusoidal area. Palatal discoloration or ulceration is a very strong pointer towards fungal infection. Presence of skin nodules, while they may be seen with Pseudomonas or Staphylococcus as well, but they are also seen quite frequently with fungus. And if angioinvasion is typically more common with Mucor, so presence of hemoptysis, etc., may commonly occur with presence of Mucor. Overall, there is no single point clinically which helps differentiate. We really require serological assays and histopathology. So you can see in this photograph, there is this child, he had leukemia, and you can see that there is a palatal hole and a discoloration, whitish patch over here. So this child had a combined infection of Aspergillus and mucor, which was obtained from this biopsy over here, this whitish area that we biopsied. And fortunately, he recovered with a prolonged therapy with liposomal amphotericin B and underwent plastic surgery for this damage. So how do we diagnose invasive fungal infection? I think Dr. Gaurav has already talked a lot about it. I'll go over it quite briefly, especially as we are short on time. So direct microscopy and culture is the definitive diagnostic modality. Fungal biomarkers help, molecular methods, which is already mentioned, and radiology also helps. So I'll skip the histopathology and direct microscopy. It's obvious yeast septate hyphae and aseptate hyphae are seen with Candida, Aspergillus, and mucor respectively. Serological assays, galactomannan and beta-D-glucan are the important ones for us clinically at the bedside. It is helpful if they are positive. However, the negativity does not rule out invasive fungal infections. And the caveats with serological assays are that there are several reasons for false positivity. If the child is on drugs like piperacillin, tazobactam, or amoxiclav, then it may be false positive. In case somebody opened the vacutainer and did an improper collection, then again, there would be strongly false positive. Blood transfusion, platelet transfusion, severe mucositis may lead to positivity in certain situations. And importantly, it is negative in mucormycosis. We don't have any great test to predict mucormycosis. And because of multiple reasons, it is not too variably recommended under various guidelines for as a screening test in children with febrile neutropenia. So I think galactomannan values were already mentioned in the previous talk. There is a weak recommendation for use of galactomannan as a screening test during febrile neutropenia because of poor positive predictive value and limited usefulness of the high negative predictive value. Beta-D-glucan is positive in multiple fungi, so it is sensitive but not specific. It has a high negative predictive value for candidiasis of 90 to 95%. So if it is negative, we are happy that it is not candida at least, but it has a low positive predictive value, and it combined with either procalcitonin or CRP can be more valuable. And if multiple tests are positive, 2 consecutive tests are positive, then it is a more valuable assay, and it can help predict safe discontinuation of therapy. So the various sensitivities and specificities which are currently thought about in pediatric oncology, sensitivity of galactomannan is 89%, beta-D-glucan is 76% compared to PCR, which is 76%. Sensitivity is above 80% for both the serological assays. However, the positive predictive value is not very high. Because of this reason, the current guidelines for management of fever in febrile neutropenia in pediatric patients says that we should not use serum galactomannan and beta-D-glucan as a routine screening tests. Radiological investigations, Malav already showed the CT initially. What all we can see in the CT chest is dense circumscribed nodules with or without a halo sign, air prison sign, a cavity may be seen at times, or a wedge-shaped segmental or lobar consolidation may be seen. However, these classic findings are usually absent in children. So we can do a CT scan without a contrast media, look for all these signs, but typically what we see most common is scattered nodules with ground glass opacification, as was seen in the initial case that we discussed. So the treatment of invasive aspergillus, the drug of choice is voriconazole. The dose in pediatric patients is 9 mg per kg, and initially it should be given as an IV to ensure appropriate blood levels of voriconazole are attained. And subsequently only oral voriconazole should be given. It should be given for a period of 6 to 12 weeks. Therapeutic drug level monitoring is required. We do it at PGI, and we see both very low values and very high values at times. So, and we need to adjust our doses accordingly. There is a lot of drug interaction, especially with vincristine. So we need to be cautious about use of chemotherapy agents along with voriconazole. And we need to remember that Aspergillus niger is inherently resistant to voriconazole. Directed surgery and improvement of host immunity, as for Candida, is required to successfully treat invasive aspergillosis. For refractory or non-responsive aspergillus, combination therapy is something that we often talk about. So the combination to be used is voriconazole plus an echinocandin like the capsofungin, and which we can subsequently step down to voriconazole monotherapy after improvement. It is shown to have better outcomes than voriconazole monotherapy. And alternately, if we are seeing non-response, then we can use single agent liposomal amphotericin at 5 mg per kg. And we need to remember that some of these children may not be responding to voriconazole because of either acquired resistance or inherent resistance. Treatment of mucormycosis, aggressive surgery shows improved outcome of lung and sinus infection. Liposomal higher doses may be given between 5 to 10 mg per kg per day. Posaconazole and isavuconazole are the alternate agents which can be used. And we definitely need to stop chemotherapy. And in children in whom we are anticipating that they may recover their neutrophil counts and immunity after a bit, then we have to give them support with GCSF definitely and granulocyte transfusion in certain cases. So granulocyte transfusion are required for multiple days till the ANC rises beyond 500 to 1000 at least consistently. Liposomal ampho is better tolerated than plain ampho with less toxicity. Higher doses can be administered. There is an equivalence of outcome of dose of 3 versus 10 mg per kg in cases of aspergillus. So the dose of 3 to 5 is considered to be sufficient for aspergillus, and higher doses are reserved for mucor. So posaconazole is approved above 13 years of age, but it is used in younger children all the time, and it is used as a second-line salvage treatment for mucor and aspergillus. Therapeutic drug level monitoring is again required for posaconazole. I think I'll just stop here because I've already overshot the time, and with this slide on of antifungal overview. And Dr. Anna, I'll just stop here then. Thank you.
Thank you very much, Dr. Richa, for that very lucid overview of management of fungal infections. Thank you again to everyone who presented today, Dr. Malav, Dr. Gaurav, for bringing this presentation together. I actually don't see any questions in the chat box, so I thought I'll ask one myself. I have two questions. First one actually to Dr. Gaurav. So some of us in other centers probably don't have all the the rapid candidate test or both beta-D-glucan and galactomannan. We usually have one or the other. So in that sort of situation, I know the recent guidance says don't do the galactomannan and the beta-D-glucan. We're a little bit stuck when we have a sick patient and we're waiting for the cultures to come through. Do you think we could still use a serial galactomannan measurement as a reasonable measure of fungal infection that is recrudescing or appearing, and is there a role for screening all patients with a galactomannan at baseline?
Ma'am, thank you for this question. We generally follow a two-step method. We first screen the patient for the PAN marker, that is BDG, and if positive, that obviously in serum samples, then we do the galactomannan levels. For respiratory samples, obviously it is not standardized for on BDG. So all respiratory samples, we directly proceed for galactomannan levels. The whole idea is we still follow the protocols of doing the serology test, because it depends upon whether it also depends upon the cutoff that we are looking at. So if we're looking at it as a screening marker, then we use a lower cutoff. If we look at as a diagnostic marker, then we keep a higher cutoff to get the higher negative predictive value. This has helped us in the sense the cultures are being negative. As I mentioned, the positivity rate is almost 20%. And it gives the clinicians no kind of idea whether to start antifungal prophylaxis or not. So we still go with the serology markers. in hand with cultures. Whether, I mean, although as Dr. Richa has already mentioned, the recent guidelines do not advise it in pediatric patients, but then it leaves us with nothing in hand to come to, I mean, to provide any kind of support to the clinicians about whether to start or to stop any kind of antifungal therapy that the child is on.
Thank you very much. There's a question for Dr. Richa. In probable and possible fungal pneumonia, what should the duration of the antifungal therapy be?
Right. So that's a great question, and this is the typical situation that we see clinically. In a probable in both the situations, definitely we need to give till the child has a resolution of his febrile neutropenia of whatever lesions he has had. However, if the child was in a very bad shape, if he has had a bowel which was growing aspergillus, though this is not proven, but this still would be a very strong suspicion. If gallic-mannan was positive, CT was bad, then we would end up giving it probably throughout a prolonged period of neutropenia in a child with ALL who develops something like this at the end of induction. We might end up giving him this antifungal prophylaxis till the end of delayed intensification to ensure, as a secondary prophylaxis basically, to ensure that he does not develop a bad fungal infection again. So it's a clinical decision taken at a bedside. In a very bad situation, in a child who had been very sick, we definitely would, and we have a very high reason to suspect fungal infection, then we would give it for longer period. In a child who had just did that particular episode, and maybe not treat him again unless there is a very prolonged period of neutropenia.
Thank you for that. I had one further question actually. So in your experience with giving the prophylaxis for the ALL patients who are frequently on vincristine,
Right.
what has been your experience with the supposed neurotoxicity with the interaction, and if that has been a real concern, how have you got around it?
So, Dr. Vandana, great questions. What we have seen is both, because we do try to do voriconazole drug levels in most of the children who have issues. We try to look at the levels as the first thing, but in day-to-day practice, for most of the children, we are not able to do it all the time. In those, and we are very particular about stopping voriconazole 24 hours before the next dose of vincristine and restarting it at least 24 to 36 hours after the next dose of vincristine to prevent interaction, because neurotoxicity, like you said, does happen. And voriconazole related neurotoxicity we have seen, in which case we do a drug level monitoring and we reduce the dose as required. So that is what we do. I don't know. What do you do? How do you handle?
So very similar sort of thing. Everybody gets voriconazole 5 days a week, and then 2 days a week they don't get it during induction, certainly, but in consolidation it's a bit better because there is really no vincristine. However, the thing is, if you drop it for 48 hours in between, does it really have the desired therapeutic effect? Is the question. But anyway, I don't think there's a very good answer to that, and most of our patients really can't afford either liposomal amphobi or caspofungin as prophylaxis. So that's the situation that we are in.
But all said and done, we have definitely seen a reduction in the percentage of fungal infections. I don't have the exact data of the current eye cycle, whether what is the fungal infection at our center. But with prophylaxis in AML, definitely we have seen a reduction of invasive fungal infection.
There's one further question actually about what is the right time to do the voriconazole level.
So it's meant to be a trough monitoring after about 5 to 7 days of starting voriconazole. We try to do at least a couple per patient. If they are being treated for longer periods of time and if they have had multiple issues. We don't do for every child who receives prophylaxis because it's just practically difficult to get it done and expensive for the patient as well. But in children who have issues and who are going to get voriconazole for longer periods, small multiple drugs, then we do give for longer period. I think there is another question about antifungal prophylaxis for AML patients and HSCT patients. So AML, we are giving voriconazole throughout, even in their non-neutropenic fever, because I think world over data shows that AML is quite a prolonged periods of neutropenia. Transplant at times is easier. Autologous transplant is definitely easier than AML treatment is for us. And HSCT, I personally don't have a lot of experience with HSCT. I think every center has their own drug of choice. Duration of withholding posaconazole. So azole is typically 24 hours before and after a dose of vincristine. That is the rule of thumb that is recommended at most of the places. That is what we follow.
Okay, fantastic. So I think, one more question. Role of secondary prophylaxis in possible fungal pneumonia patients.
I think it's a continuation from the initial discussion for when we are standing at the bedside and we have a very strong suspicion the child has been very sick, went to ICU, got intubated, but we did not actually kind of have a histopathological lung tap or something, but we have a strong suspicion, we would treat that patient. For possible, again, you have to stand at the bedside and take a call at times, but for just a few nodules and a child who has recovered very rapidly, we would not give, I would not give prolonged therapy, definitely. But it's a case-based decision, I think.
And there's another question on in possible fungal infection with the radiological change. So probable fungal infection.
That would make it
if
probable,
there is
yes.
that would make it probable. Yes, exactly. So if there is no major radiological clearance, the question is, if you've given the 12 weeks of therapy, there is count recovery, but there is no radiological clearance, would you still continue the antifungal therapy?
I think that would be a very unusual situation. And if we are early on not seeing resolution, then we would biopsy. We would try every way we can to get to the lesion to see what it is that we are exactly dealing with. Are we missing something else altogether? It may be TB, it may be anything else. So that's what we would do rather than just continue with the treatment, which may or may not be directed towards what is underlying.
Okay, so I think that brings us to the end of the session nicely. It's 8:17, so I think we're meant to finish at 8:15. So thank you, everybody, for a wonderful session, for a wonderfully interactive session. Dr. Malav, Dr. Gaurav, Dr. Richa, thanks so much, and thank you, everybody, for logging in. Just before I say goodnight, I will just brief you about next month's session. So this is August 10th. It's a case discussion actually from one of our colleagues in Columbus, Ohio, Dr. Bajwa, on LCH pancytopenia immunodeficiency. So this is a difficult case scenario, and we will have a bit of a panel discussion. So panelists, Dr. Revati from Apollo Chennai, Dr. Chetan from TMH Mumbai, and Dr. Vignesh from PGI Chandigarh. So this is the immune deficiency LCH pancytopenia milieu coming up for us next month, August 10th. But we do hope to see some of you in the midterm FOCON before that. Okay, all right then. Thank you very much, everybody. Have a good evening, and thanks again. ECHO team, thank you very much for the platform. Thank you, IAP PHO, Dr. Amita and Dr. Neeta for encouraging us and supporting us to go through with this. Thank you, everybody. Good night.